Good morning. My name is Tess Farley. I'm a urology nurse specialist here in Crumlin Children's Hospital. I'm joined here today with my colleague Orla King, and we're going to be discussing the bladder care and management for people with spina bifida. So I'm just going to start off initially with the anatomy and physiology, and then my colleague Orla will discuss urinary tract infections and clean intermittent catheterizations. Okay, so here we have the urinary system. So this comprises of two kidneys, and you'll see them here in the dark purple. So these extract waste materials from the blood and convert it into urine. We then have two ureters. You'll see them here in grey, these two grey tubes. So these run down from the kidney to the bladder. We then have the bladder here in a lovely light pink colour. This is a triangle-shaped organ that is used to store urine produced by the kidneys. We also have two sphincters at the very base of the bladder here, and these are muscles that relax and contract to allow storage and passing of urine. We then have the urethra at the very bottom here of the bladder, and this is a tube that runs from the bladder through the penis in males or the vulva in females, through which urine is expelled from the body. Sorry, I'm just, oh yeah, there. Okay, so now we're going to look at the sagittal plane of the female bladder. So we have the ureters here, as we said in the grey, we have two of those coming down and they come into these little eyelets here into the bladder. So these carry, as I said, the urine from the kidneys. Here we have the body or the dome of the bladder. And then here we have the trigone. So the trigone stretches from these two eyelets, the ureteric orifices, into the bladder. So you'll see it's like a triangular shape. And this is a very sensitive area of the bladder. As the bladder becomes full and expands, it sends signals to the brain to then empty the bladder. So here now at the very base of the bladder, we have the bladder neck. And at the very bottom here of the urethra, we have the external sphincter. And that's a muscle there. So in the bladder itself, you have a muscle that surrounds the outside of the bladder. This is called the detrusor muscle. And you can see it here in a light grey colour. It goes around the outside of the bladder itself. We then have these two openings coming in from these ureters that are coming down from the kidneys where the urine drains into the bladder. And these are the ureterovesical junctions where the ureters, as I said, join the bladder. We then have the internal sphincter here at the very base of the bladder. Coming from that, we have the urethra coming through the middle here, and this is where the urine drains from the bladder through, and then it's expelled outside to the body. So just recapping on it, we have the internal sphincter, just here. Then we have the external sphincter, those are muscles. And then at the very bottom, we have the pelvic floor muscles. So the pelvic floor muscles support the pelvic floor organs. These are the bladder, the bowel, and the uterus in females. Okay, so then we have the normal bladder function. So we have filling and storage stage. So this is where the detrusor muscle here that goes around the outside of the bladder. This is when this muscle then begins to relax as the urine comes in through the ureters into the bladder. So as it's filling, the bladder and the muscles around it relax to allow it to fill up. The bladder neck then closes, and these two sphincter muscles we discussed, the internal and the external sphincter muscles contract to close tight. So this allows the urine to stay in the bladder and for the bladder to store that urine. We then go on to the voiding phase, also known as just wean. So here the bladder muscle around that detrusor muscle, they begin to contract. And while it's contracting, the internal and the external sphincters relax along with the pelvic floor muscles. And this allows the urine from the bladder to drain out through the urethra. Then we have the termination of voiding, and that just means the end of the wee. So any urine inside the external sphincter, any urine above that, is squeezed back up into the bladder. Oh, sorry, I just jumped across too quickly there. The external sphincter contracts, the internal sphincter contracts, and the bladder neck closes. So these will all close over again at the very end of the void. So the physiology of voiding. So a neurogenic or neuropathic bladder is a bladder that doesn't empty or store urine properly due to a lack of communication between the bladder, the spinal cord, and the brain. So the nerves that control the bladder and the urinary sphincters or the muscles themselves are not working properly. This can result in muscles that are either too strong or too weak. So that's the muscles of the bladder or the sphincter muscles, the internal, the external, that we discussed. A bladder that is unable to stretch, or a bladder and sphincter that do not work together. So here you'll have your bladder, and as it begins to fill with urine, it'll send the signal up to the brain, letting it know that the bladder is beginning to become full and expanding. And the signal then usually travels down then the spinal cord here, down to the bottom into the bladder through the nerve fibers, controlling the muscles. So symptoms of a neurogenic bladder dysfunction include urinary incontinence, small urine volume during weeing, incomplete bladder emptying, also known as post-void residual. So that's when there's urine left in the bladder after weeing or after emptying. So urinary retention, and this is the inability to wee despite trying with a full bladder. So you're unable to empty the bladder either partially or completely. Urinary urgency, this is when there's a sudden, unexpected, immediate need to do a wee, or frequency, when you're weeing more often than you should throughout the day. And also a loss of feeling and sensation that the bladder is full. I know some of you may experience sensation is just a feeling of discomfort at times when the bladder is full, and you would have some awareness of when you either need to do a catheterization or go and empty the bladder. So complications of a neurogenic bladder include urinary tract infections, so renal scarring. So here you have in the grey the ureters traveling, just connected up here to the kidneys. So with urinary tract infections, the bacteria and the infection can travel back up into the kidneys, and this can cause pyelonephritis. So just talking about the hydronephrosis, first of all there. The hydronephrosis is the swelling of one or both kidneys due to a buildup of urine. It may be due to high pressures within the bladder causing ureteric reflux. So the ureteric reflux is these ureters. So the normal flow of urine would be from the kidneys where the urine is produced, and it would flow down the ureters into the bladder. With ureteric reflux, because of the high pressures in the bladder, the urine is then pushed back up towards the kidneys. And if the urine is infected, that will cause infection in the kidneys, known as pyelonephritis. So pyelonephritis can occur in one kidney or both kidneys due to a bacterial infection. It can be caused by a urinary tract infection that travels from the urethra or bladder up to one or both of those kidneys, as I said. Signs and symptoms of pyelonephritis may be fever, flank pain, nausea, or frequency. And we'll discuss that later on in the lecture, the signs and symptoms of urinary tract infections. Another complication can be kidney stones. So kidney stones form when the minerals are concentrated in urine. These minerals begin to crystallize and form stones. So the stones can occur either in the kidney or in the bladder. So urinary incontinence. Urinary incontinence is a loss of bladder control with or without bladder sensations. This results in voiding into your underwear or your pad. This can be a continuous incontinence with a constant leak throughout the day, or it can be intermittent with urine leakage at intervals throughout the day. It is well known that incontinence can have an impact on people's quality of life and can affect any one of us. So incomplete bladder emptying, post-void residual. So that's where I explained in the other slide where there's urine left in the bladder after a void or a wee. So post-void residual. So the bladder is not empty after weeing. A residual volume of urine is left stored in the bladder. Ideally, a minimal amount of urine is left in the bladder after voiding. And what we would like to see is the amount left in the bladder after voiding would be at least 10% of the expected capacity of that bladder. May contribute to health complications or quality of life issues such as urinary incontinence, urinary tract infections, vesicoureteral reflux, or hydronephrosis. So complete urinary retention. So this can either be acute or chronic. So acute urinary retention usually is a sudden onset, where chronic urinary retention is built up over a period of time. This is where there's inability to completely empty the bladder and where it's persistent, reoccurring over time. And it leads to incomplete bladder emptying, as I said. So the treatment plan for these, for leaving residuals in the bladder or retention, is to commence intermittent catheterizations to ensure that the bladder is empty, all the urine is removed, and reduces the chance of infection or this reflux then up towards the kidneys. So a neurogenic overactive bladder, what is it? So it's an involuntary bladder muscle contraction during the filling phase when the bladder muscle should be resting. This can cause symptoms of urgency, frequency, and urge incontinence. So this is where there's an incomplete bladder emptying because it's so overactive, or over time a bladder which will only hold a small amount of urine. And this is due to the overactive bladder squeezing out urine, the bladder not getting a chance to expand and fill as to hold larger amounts of urine, and as a result, it tends to hold small volumes of urine throughout the day. Treatment. What does this include? Treatment will vary from patient to patient. The primary aim is to prevent kidney damage, provide a good quality of life with social continence. Conservative and proactive treatment is the first line. So one of the things to remember here is each child or each person that presents with spina bifida, their bladder will present differently. You may not be on the same treatment plan as someone else you know with spina bifida because their bladder may work differently. Some of those treatment plans will include medications to relax the bladder. These are known as anticholinergics. Emptying the bladder with a catheter regularly, known as clean intermittent catheterizations, and preventative antibiotics to reduce infection. Or you may require continence surgery. So for the medications, the first line of treatment is anticholinergics. You might be familiar with these names, oxybutynin and tolterodine. So these medications help the bladder relax. So this is useful for a bladder that has high pressures, where when the pressure is high in the bladder, the urine is squeezed back up through the ureters up into the kidneys, or when the bladder is overactive and it's squeezing too often and you want it to relax. Often you may present with a bladder that is leaking a lot, and when you're doing your clean intermittent catheterizations throughout the day, your pads are wet in between. So one way to try and get a social form of continence and get the pads lighter and drier would be to introduce an anticholinergic medication. So this will help the bladder relax, and in turn, it'll hold more urine. So this gives you a window of opportunity where if you're catheterizing 3 to 4 hours throughout the day and your pads are still wet in between, that this medication may help the bladder hold more urine, and you could change that routine of maybe doing your catheterizations every 2 to 3 hours with an attempt to try and get socially continent in between. If these medications fail, another treatment would be Botox injections into the bladder. So this can either be into the bladder, the detrusor muscle that we discussed earlier, or into the bladder itself, or the sphincter muscles, depending on what the treatment plan is required. So I just realized there, I'm just flicking through these images. If you don't mind, I think I missed one of the slides. I might just go back and have a look here. Yes, this one here. Sorry about that. I just didn't realize I flicked through this slide. Just want to explain you the differences between the different variations of a neuropathic bladder. When I explained earlier that each person may present differently and each person's treatment plan can be different. And this is the bit that can be confusing when I hear from some parents saying, well, you know, another person I know with spina bifida is on medications, they're doing clean intermittent catheterizations, but they will need surgery. Do I need that surgery? What do I need? And it does depend on what type of bladder you have and how it functions. So just to explain to you there, you have the bladder itself, the detrusor muscle around the outside of it. This muscle can either be too active and squeezing too much, or it may not be active at all and may not squeeze. Then you have those two muscles, the internal and external sphincters. And again, they can either squeeze too much and hold the wee in, or they can be too relaxed. And then the discoordination between the bladder muscle and these sphincter muscles. So there's typically 4 types of neuropathic bladders. So just to explain this one here is where the sphincters contract when they should be relaxing, combined with the bladder muscle that relaxes when it should be contracting. Then we have the sphincter contraction during bladder muscle contracting as it's trying to empty. So that's the bladder muscles are contracting and the sphincter muscles when it should be trying to relax to empty. We then have a non-contracting sphincters and no bladder muscle contraction at all. Or your bladder may be a bladder that has an incompetent sphincter and a sphincter that does not contract combined with a hyperactive bladder muscle. So these typically are the 4 different variations of a neuropathic bladder, and depending on what type of bladder that you have will depend on what treatment plan you require. I'm just flicking through here just to make sure I did cover those slides. I know I went a little bit fast. Sorry. Okay, so I'm going to hand you over to my colleague now, Orla King, and she's just going to talk through urinary tract infections and cling intermittent catheterizations.
Thank you so much, Tess. Hi everyone, I hope you're enjoying it so far. So I'm going to start off with UTIs, also known as urinary tract infections. So what is a urinary tract infection? So a urinary tract infection is when bacteria or germs, which can often be from your rectum, travel through the urethra and into the urine in your bladder. They affect usually 3 parts. So usually the urethra, which is also known as urethritis. This can have symptoms such as frequency, urgency, and pain. It can also affect your bladder. This is known as cystitis, and this is actually the most common type of urinary tract infection. Symptoms for cystitis can include tiredness, dark, cloudy, smelly urine, pain, and sometimes urgency and frequency. There is more seriously when it may reach the kidneys, and this is known as pyelonephritis. This is usually caused by the infected urine flowing backwards from the bladder into the kidneys, and it causes the kidneys to swell and may also cause damage to them. Sorry, excuse me. So the infection can occur from the bloodstream as well, and it can reach the kidneys through the bloodstream. Recurrent urinary tract infections can result in scarring of the kidneys and may cause irreversible damage. So treatment goals are to eliminate the infection and to prevent further kidney damage. So this is really, really important. So one of the main things for treatment is to obtain a urine sample and bring this to the lab either by your GP or your healthcare professional. And it is sent to the lab and it is analysed for culture and sensitivity. So this allows us to know what type of bacteria is growing in the bladder and also what is a suitable antibiotic to treat this bacteria and eliminate this infection. With the likes of the pyelonephritis, usually people and children would be a lot thicker with it. They'd have a temperature, they'd have frequency, pain, cloudy and offensive urine, nausea, vomiting, and may have an increase in wetting. So what are the predisposing factors for urinary tract infections? So one of the main ones is incomplete bladder emptying. So this is where your bladder is not emptied completely and stagnant urine is left in the bladder for a prolonged time. This allows for a perfect environment for bacteria to grow, as it's warm, it's dark, and it's moist, and they thrive in such an environment. Constipation can also cause UTIs. This is due to the close proximity of the rectum and the urethra. And with a full rectum, this can then press on the bladder wall and can cause increase in spasm or outflow obstruction, and this then causes incomplete emptying. Bladder bowel dysfunction, and this includes symptoms such as constipation, wetting, and urgency. VUR, or vesicoureteric reflux. Tess has mentioned this before, and this is when the urine flows backward from the bladder into the ureters during urination and can back up into the kidneys and cause infections. And catheterization, such as indwelling and intermittent, and this is usually the catheter is introducing bacteria into the bladder. There are also certain types of antibiotic therapies for other illnesses that may make you more inclined to get a UTI from using them. So what can we do to help you prevent UTIs? So adequate fluid intake is really important, and we aim for 1.5 to 2 litres per day of regular drinks. Constipation definitely needs to be treated, so it's really important that if you do suffer from constipation, that you are put on a bowel management program. This may start off with a bowel clear out if it's deemed necessary, and then to follow on with stool softeners such as Movicol and Dulcasoft, and you may need a stimulant such as Senna. Regular complete bladder emptying is optimal, and we aim for 3 hourly bladder emptying, either through CIC or voluntary voiding. Strict hygiene is important also because it will help reduce bacteria. So we must ensure that the urethra is kept clean on a regular basis. Catheter size and type, so the appropriate size for your age and bladder size is really important. If you are using a catheter that is too small, it may be slow to empty, and therefore you may be less likely to empty your bladder. If it's too big, this may cause urethral trauma. So methods of bladder emptying. So there is voluntary and involuntary voiding or weeing. So if you're doing your wees independently, this would be known as voluntary. If it's involuntary, this would be known as incontinence. So there is the option of catheterization. So there is clean intermittent catheterization. There is use of an indwelling catheter, a suprapubic catheter, and also a Mitrofanov channel. So clean intermittent catheterization. This has been established as a safe and effective treatment for bladder emptying in clients with spina bifida, and is also known as a gold standard treatment. It assists in achieving optimal continence for you as an individual. These are performed on a regular schedule to minimize the risk of urinary tract infections or complications such as hydronephrosis or renal damage. This can be performed through CIC, through the urethra, or also a Mitrofanov channel. So complications of clean intermittent catheterization. So if you have no urine or poor urine drainage while trying to do your catheter, it may be that the lubricating gel may have blocked the eyelets. Ensure it is also in the correct orifice if you're a female, and that it is in far enough. If you're unable to insert a catheter, do not force it. It may be caused by increased sphincter tone at the opening of your bladder due to anxiety or spasm. So relax and take a deep breath. If you are unsuccessful, remove the catheter and try again in an hour. Urinary tract infections, these usually occur due to poor technique, urethral damage, and the mucosal barrier becoming damaged, and it then allows the infection to become present. Urethral stricture, this is narrowing of the urethra, and this occurs usually due to scarring. This can result in the restriction of flow of urine from the bladder, and therefore can result in inflammation or infection. A false passage, so this can usually occur due to trauma, due to poorly lubricated catheters, or forcible catheterization. Bleeding may also occur, and again, this can be from trauma, but it can also be a sign of a urinary tract infection. So it's always important to check with your healthcare professional if you have any concerns. So the benefits of intermittent catheterization, it does allow for a healthier bladder. It allows the bladder to fill up and empty completely, and will reduce the occurrence of UTIs. It helps you achieve optimum continence. It promotes independence. It helps maintain sexual relationships and improves quality of life. So routine. A routine is really, really important if you're doing catheters. So timed CIC is one of the most valuable methods of preventing urological complications in a neurogenic or neuropathic bladder. The optimal time is usually 3, max 4 hours between catheters, with 4 to 6 catheterizations per day. A time schedule for catheterizing is crucial for those with altered bladder sensations, and this just ensures that the bladder is emptied regularly. Ensuring a good technique in catheterization to ensure the bladder is emptied correctly on each catheterization. It also assists in achieving continence when done routinely at a schedule individualized to you and your bladder function. So another type is an indwelling catheter, and this is another option, and it can be either a short or a long-term urinary management plan. If it is long-term, these do need to be changed usually every 10 to 12 weeks. An indwelling catheter is a catheter that is inserted into your bladder either through the urethra or above the pubic bone. Depending on the material, it will stay in place for several weeks, and it has to be replaced regularly. It does need to be connected to either a urinary bag or a catheter valve. So if it is a urinary bag, it's usually that you require free drainage, where if it is appropriate for you to use a catheter valve, that is also known as the flip flow valve, and this allows you to do clamp and release. So this is where it is clamped off, your bladder fills, and you empty it regularly, usually every 3 hours. So complications of an indwelling urinary catheter. So the main, the main complication is infection, and this is usually because there is a foreign body introduced into your body. Spasm, so this can be from the balloon of the catheter irritating the bladder or the trigone area. Blood in the urine, again, this can be a sign of UTI, so if concerned, do get it checked out, or it can also be a sign if it is blocked. A blockage can occur when the eyelets have become blocked or the catheter may be kinked. Leaking and bypassing can occur when urine can't drain out, so it is important to check the catheter for any kinks, as it may be due to the tube just being kinked. It also, leaking and bypass can also occur due to blockage. So a suprapubic catheter then is a hollow tube catheter placed in the bladder through the tummy wall to drain urine. They usually a Foley or an open tip catheter is used for this. And again, these would need to be changed every 10 to 12 weeks. It is anchored in place by a small balloon of water in the catheter tip and then secured to your abdomen with elastoplast tape or a grip lock Velcro holder. It drains either continuously into a urine bag or is drained at intervals using the flip flow catheter valve every 3 to 4 hours. So that concludes our little talk. I think we're going to take a break for the moment for a few minutes, and then Ray from Hollister is going to give a little talk. Thank you.
That's brilliant, everybody. We'll be back in just a few minutes. So if you want to grab yourselves a little drink or anything like that, and we'll be back to you. Thank you very much. just while we're waiting there, a reminder to everybody that next week's webinar is by our Relationship and Sexuality Working Group, and it is in relation to consent. Okay, and we're ready to start again now, and just want to thank you all and hand you over to Mairead. Thank you very much.
Thanks a million, Katie. So hello, everybody. My name is Mairead Maguire. I'm a Senior Territory Manager working with Hollister. I'm absolutely delighted to get the opportunity to present to you today and introduce our Vapor range of intermittent catheters. And I also just want to say a big thank you to Spina Bifida Ireland for this opportunity. So firstly, I would like to tell you a little bit about Hollister. So Hollister was founded in 1921 by John Dickinson Snyder. Our global headquarters is based in Libertyville in the United States of America. We currently have 6 manufacturing facilities throughout the world, one of which I am very proud to say is here in Ireland, in Ballina, County Mayo. Our mission at Hollister is to make life more rewarding and dignified for the people that use our products and services. So now I would like to introduce to you our newest range of Vapor Pocket and Vapor Plus Pocket intermittent catheters. So as you can see here, Vapor Pocket does not have a bag attached, and Vapor Plus Pocket has a bag attached, so it's a closed system. This is a picture of the discrete packaging and boxes the catheters are stored in when you collect them from the pharmacy. So you can see exactly here how neat, compact and discreet these catheters are. The Vapor Pocket range of catheters offer a 100% no-touch protection. They are hygienic by design to help protect patients from germs throughout the entire catheterization process. The Vapor Pocket range of catheters have both a protective tip and a protective sleeve. The protective tip helps shield the catheter during insertion from bacteria located within the first 15 millimeters of the distal urethra, and also helps reduce the risk of carrying bacteria into the urinary tract. The protective sleeve allows for the catheter to be gripped anywhere and provides a barrier to the catheter to help keep germs away. The combination of the protective tip and sleeve creates a no-touch system that is easy to use. It's ready to use right out of the package with no extra steps required. If you look at the first picture on the left, you'll see the catheter is designed with smooth, rounded eyelets to enhance user comfort during insertion and withdrawal. In the middle picture, you'll see the packaging is designed with finger holes to be easy to open. And finally, in the third picture, it's pocket-sized packaging for easy transportation and discreet out-of-home usage. With 100% no-touch protection, whatever you touch won't touch Vapro no-touch intermittent catheters. So now to look at how the protective sleeve works and what happens when you touch a catheter with your fingers. So in these pictures under the UV light, you can easily see the bacteria present on the person's fingers. If you look at the picture on the left, this is an unprotected catheter, so it has no sleeve. The bacteria present on the fingers easily transfers onto the catheter when touched. Whereas, in the second picture on the right, the sleeve of the Vapro catheter is there to protect the sterile catheter against touch contamination. The Vapro catheter sleeve has been proven to prevent the transmission of pathogens that may cause urinary tract infections, such as viruses, bacteria, fungi, and parasites. So now to look at how the protective tip works. If we look at the first picture on the left, it explains how the catheter is advanced into the protective tip, and then the protective tip is inserted into the urethra. Looking in the middle picture, the protective tip helps prevent the catheter from coming into contact with the bacteria that are predominantly in the first 15 millimeters of the urethra. And then finally, in the third picture, the protective tip helps protect the catheter from becoming contaminated. So to summarize, by choosing a Vapor Pocket or Vapor Plus Pocket intermittent catheter, you have 100% no-touch protection. On our website, www.hollister.ie, you will find our product information page explaining how to use our products, patient testimonial videos, and the 100% no-touch demonstration video. The link shown here will take you directly to the product information page. We also have an e-learning centre that includes various educational articles, along with information on intermittent catheters and bladder health. The link shown here brings you straight to our e-learning centre. So to conclude, I would like to thank you for listening and thanks Bladder Ireland for this opportunity. Please contact me directly or our customer services team on the numbers shown if you have any questions or would like any samples of our products. Thank you. Thanks, Katie.
Yeah, thanks a million, Mairead. Sorry, I was typing furiously there to say that the question and answer section is open. If anybody has any questions for everybody there, for Mairead, Tess, and Orla. So any questions our way, please type them in now. And just want to thank you all for coming today. Your presentations were very interesting. And yeah, every day I learn something new when I'm on this. So I really appreciate that and appreciate you giving your time as well to talk on our webinar and for allowing yourselves to be recorded. It's very much appreciated. It's a resource that while not everybody can attend the webinar today, that it's open then to anybody else who wants to listen back at a later stage. We have one comment in there that it was a great presentation and thank you. Yeah, so we don't have any questions at the moment. You've done such a great job. You don't have any questions, but I just want to thank you again so much. It was very interesting and I really appreciate it. And we in SPHI really appreciate it.
Thank you all as well.
Thank you for listening.
Your specialty here. Thank you.
Thank you very much again, and I'll say goodbye to everybody. Just a reminder that next week's webinar is on sexuality and relationships, and it's with our family support worker, Paige Parker, and she will be running a session on consent. So thank you very much again for attending. And one other comment there that thank you all. It was really interesting. So thanks again, ladies, and yeah, have a great afternoon and stay safe, everybody.